Good evening, everyone. Good evening, Professor Al-Mefty. Good evening, Professor Tanikawa. It's a great pleasure to start one more session of our seminars we call Al-Mefty Neurosurgical Series on honor of our great professor and friend, Professor Al-Mefty. Today, I have the great pleasure to have with us Professor Tanikawa. Is a very well-known neurosurgeon from Japan, and the man that give you us a neurosurgeon, a new dimension of different disease that you can, especially the ischemic disease that now the neurosurgeons are full involved. Thank you, Professor Tanikawa. It will be a great pleasure to have you here and listen and see your wonderful dissections, wonderful videos, and wonderful teaching. Thank you very much, sir. I give the word to President of SONESP, Professor Carlos Veiga, that will talk in name of the society, and Dr. Koji that will introduce our guest. Thank you very much to all the participants.
Thank you, Borba.
Go ahead.
Good evening here from Brazil, and good Friday morning in Japan. On behalf of the Association of Neurosurgeons in the state of São Paulo, welcome everyone. Continuing our Al-Mefty series program, today our honored guest is Professor Tanikawa. It is a privilege and a great pleasure to be able to count on his presence in this webinar. I'd like to Koji Tanaka, please, would you introduce Professor Tanaka? Thank you.
Okay, thank you, President Dr. Veiga. I'm very pleased and honored to introduce Dr. Tanikawa Hokuya, or Tanikawa Hokuya Sensei, as called in Japan, from Sapporo, Hokkaido, Japan. He was graduated on Asahikawa Medical University in Hokkaido. And in the moment, he's the Senior Vice President, Director of Department of Neurosurgery and Stroke Center of Sapporo Teishinkai Hospital in Sapporo, Hokkaido, Japan. He has hundreds of publications on skill-based and neurovascular surgical treatments and have several citations all around the world. He's a faculty on a Schoolap Academy, one of the director, of course, of Sapporo Live Micro-neurosurgery course in cerebral vascular surgery and school-based surgery, the last one in 2019, July, in Japan, Sapporo. He too developed the super bypass instrument series with the Takayama Medical Instruments Company in Japan. And he's a director of annual Lawton Tanikawa Western East Vascular Neurosurgery course called The Last Samurai at Barrow Neurosurgical Institute in Phoenix, Arizona. Please, Dr. Tanikawa, it's a very great pleasure to have you here this night here in Brazil to your lecture, to your presentation. Thank you.
Thank you very much. Thank you for introduction for me. Professor Tanaka, thank you very much. I'm going to share my screen. Can everybody see it? Can you see it?
Yes.
Perfect. Very well.
It's working. The slide is changing. Can you see it?
Yes.
Okay. Thank you very much. Thank you for your invitation to such a wonderful webinar in Brazil. It's my great honor and a great pleasure to talk my experience in Sapporo and Abashiri around in this 20 years. It's nowadays the revascularization for regardless acute or chronic cerebral vascular disease is decreasing because of failure of cost study. But still, the revascularization is a very important part of neurosurgery. Today, I'd like to share my experience about the chronic revascularization for atherosclerotic disease like the chronic ICA occlusion or MCA occlusion. And in a late part of my presentation, I'll show you my experience of acute revascularization, including the open craniotomy, embolectomy, and endovascular recanalization, and rescue of a failure of endovascular recanalization complications. Okay. Before beginning my presentation, again, I'd like to thank Professor Borba and Professor Al-Mefty, and for everybody of Brazilian Neurosurgical Society. Thank you very much. Now, I'd like to start my presentation. Everybody knows surgical procedure of STMC bypass for chronic ischemia is one of effective procedure. The indication is like this in a hospital. The patient must have the power stage 2, and cerebral vascular reserve should be less than 10% after the diamox challenging on single photon emission tomography. And before surgery, I force patients quit smoking, and I strictly control the diabetes mellitus. The hemoglobin A1C should be less than 6 to 2% for at least 3 months before surgery. And usually we do STA, MCA single or double bypass, and recipients should be M2 to M4 segment. And in donor STA graft, I always perform the fish mouth trimming and interrupted 10-0 or 909 suture with a straight incision of a recipient. And both parietal and frontal branches of STA is harvested during elevation of a skin flap. This is a basic procedure of the revascularization. And the eligibility is very important to perform the micro-anastomosis. In our hospital, I force my young colleagues to achieve the skill to perform the micro-anastomosis as an end-to-side anastomosis in less than 20 minutes with 20 stitches using fish mouth trimming in dry lab with using artificial synthetic tubes. And in actual surgery, I require them to perform the bloodless distal cerebral dissection within 30 minutes. And most important thing is complete hemostasis before opening dura. This is a quite important procedure, the hemostasis, no red cell on the dura. This is an example of the videos of craniotomy, left side front temporal craniotomy, the meticulous complete hemostasis, the before opening dura. And after all micro procedure is finished, we have to close the head, including dural closure, like this. When we perform the dural closure, at the end of dural closure, I infuse the saline into the subdural space and confirm the water tightness. Watertight closure, dural closure, is a fundamental technique of cerebral vascular micro-anastomosis. And this one, the left side picture, is a drawing by my colleague Cosmonoda. This indicates the important everything of both vessel wall, donor and recipient. The intima to intima, those layers must be faced each other like this. Otherwise, we can't have the patent micro-anastomosis. The basic dimension of the fishbone streaming at the end of donor is very important. I always recommend to perform the oblique cut at the end of donor with a 60 degree and the same length cutting up, and we can make the this length of the fishbone streaming. And the distance over here should be twice of the shrunk diameter large D divided by √3. So total stitching length is calculated like this, 2.3 times of the shrunk diameter. This is the basic dimension. And another important thing is everything of both vessel, donor and recipient like this. If once we make the everything situation, we can penetrate the both hole easily with a counter force. The stitching bite should be twice of the vessel wall thickness, and the interval should be 4 times of the wall thickness. This is a basic dimension to have a no leakage micro-anastomosis. And the advantage of fishbone streaming, if we perform the 60 degree oblique cut like this, we can compare the cross-sectional area of the orifice with a mathematical calculation like this. If you perform the T connection with a perpendicular right angle anastomosis, the orifice is like this, just a pi r square divided by 4, like this. But with fishbone streaming, the ratio of a cross-sectional area of a fishbone streaming and just a simple perpendicular anastomosis T connection is the ratio is 3.6 times. The fishbone streaming orifice is much more larger, to 3.6 times. This is a very important point to achieve the good long-term patency, especially in chronic atherosclerotic change of the vessels. We have to make the orifice bigger. And actually, if the bypass is open, the arterial pressure is expanding the orifice like this. From the rhomboid orifice is expanded like an oval shape like this. So the orifice should be larger than 6.6 times of the T connection like this. Again, this is everything stitching, the drawing by my colleague Cosmo. It's very important, very important. With this situation, no thrombosis happen at the anastomosis. This is a principle of the micro-anastomosis. And one more thing, especially in atherosclerotic patient, when we perform the chronic STMC bypass for the patient, the regardless donor and recipient, the vessel wall had the atherosclerotic change, and the intima layer easily dissected like this. If you try to penetrate the needle from the adventitia to intima, the needle tip may dissect the intima layer like this. To avoid this situation, it's important to penetrate the needle from the inside to outside, from the intima to adventitia. So we have to carefully observe the condition of the vessel wall. The usually most important thing is recipient intima. The recipient intima should be completely penetrated. Then the STA whole layer should be penetrated. This is a very important point. This is a actual video of the chronic STMC bypass. Now I'm doing a Fishman streaming, and this is a double stay suture at the heel and the toe. And after all the preparation is finished, like this, mark the arteriotomy on the recipient, then you can approve the recipient. Now the time is counted. I always tell my young guys that if you spend 1 minute for one stitch, you can finish the end-to-side anastomosis within 20 minutes. If you stitch 20 stitches like this. This is the heel side and to heel side stay suture, 3 times tying. And this is a toe side stay suture with a reverse penetration to a recipient, and make the pulley with the left side forceps. Then you can avoid the too much tension on the recipient, because the MCA like this is the vessel wall is fragile. We have to be careful. And now I'm putting the other end of the other vessel wall of the STA fish mastering is put inside the recipient to avoid the mouth stitching when we are starting the stitching in one side, because the mouth stitching is easily happen in the other side during stitching of first side stitching. Now this is a first stitch next to heel. That is the most difficult part. And once you finish the one side stitching, then we have to make the microscope maximum and confirm inside whether there are mouth stitching or not. Then we can start the other side stitching. Once you make the everting situation like this, you can penetrate both layers of the vessel wall with one action, and it makes faster to finish the micro-anastomosis. This is a micro-anastomosis, and this is a summary of my experience in this 8 years. The number is not so much. The surgical indication is very strictly limited. The average age was 69, relatively elder. The female percent was 14, and mainly we have the M1 M1 segment of MCA occlusion or stenosis and ICA occlusion. And we usually perform the STMC double anastomosis, but depends on the patient condition, we just perform the STA single anastomosis. We had one case of occipital artery MC anastomosis because STA was already used in previous surgery, so occipital artery can be a donor for chronic revascularization. And the duration of temporal occlusion of MCA in OCDs, in the double anastomosis, first anastomosis duration was 20 minutes, and the second anastomosis mean was 24 or around 25 minutes. And in both anastomosis, max occlusion time was around 40 minutes. In the second one, 64 minutes. The shortest one is 16 minutes. This is wrong. This is 15 minutes. And in a cost study, in a stroke group, the cost study, the mean occlusion time 55 minutes. The non-stroke group was 45 minutes. In this group, there were no statistical significance, but in my experience, just STMC bypass, more than 30 minutes temporal occlusion time is a problem. Actually, we had 64 minutes or 38 minutes prolonged temporal occlusion time. Both of them have the recipient trouble during the anastomosis, and it took time. This is the reason why we took so long time of temporal occlusion time. But in the cost study, we are not sure what happened in these surgeries more than 40 minutes temporal occlusion time. Mean average occlusion time was more than 40 minutes. I think we should reconsider the eligibility of the surgeons to make the entry to such important prospective studies, especially for surgery. And this is a result of our series. The follow-up period is around 38 months, and we had 2 cases of ipsilateral stroke within 30 days, 5.6%. And single bypass was 7, double bypass around 30, and the graft occlusion was happened in 10 cases in 65 micro-anastomosis. 8 occlusion happened in a double anastomosis, and 1 occlusion happened double anastomosis occurred in 1 case. So the overall patency was 84%. In the patient level, the 97% has a good patency of the bypass. And the result, modified Rankin scale 0 to 2 is around 24%. This is an actual case of a 65-year-old man, left side MCA, M1 occlusion like this. The single photon emission tomography before surgery shows a steel phenomenon in inferior trunk of MC territory like this. And as well, frontal territory has a power stage 2, the less than 10% of increasing of CBF after the AMOX challenge. After surgery, the double STMC bypass fill the MC territory like this. And now this is 4 years later, the STA graft grew up so large like this. It's a very good revascularization. We have two ischemic events after surgery. One case in the right IC occlusion, we performed the STMC bypass, but post-operative day 1, the patient had the ipsilateral small infarction due to occlusion of precentral artery, and it causes a hemiparesis, MMT2. Another case in a right M1 occlusion, the ipsilateral asymptomatic parietal infarction happened on day 8. This is a case of a small infarction in post-operative day 1. The STMC bypass is performed and it is patent. Even bypass was patent, but patient have the small infarction like this. And another case, at the day 8, the STMC bypass, of course, it's patent, but the parietal lobe have the asymptomatic high signal in a diffusion image like this. So these two cases, we can understand that this kind of infection maybe happen because the patient basically have the atherosclerotic change, not only the M1 territory, but also MC cortical territory as well. This case, this was asymptomatic, but the basic atherosclerotic change may cause such a post-operative infarction. And other complications, the frequent complication is wound healing delay because of ischemia of skin flap. We have to be careful. We had 38.8% of the healing delay. That we need wet dressing of the wound is wet dressing is effective, and we had asymptomatic hyperperfusion in 4 cases. The control of the blood pressure around the less than 80 to 90 millimercury in mean pressure to control the blood pressure is very important. Modified Rankin scale like this, around the 94% was a good outcome. The excellent outcome was 77% modified Rankin scale, 0 to 1. So the patient who have the infarction after surgery, despite of the good patency of bypass, the patient have the severe bad condition of the vessels, chronic damage of the vessel wall. This is the main cause of the complication. And the craniotomy for STMC bypass, it itself may be too invasive. So just opening head, it may cause something ischemic complication. So we have to be careful. So to prevent such a complication, we should continue the antiplatelet agent during the surgery. Actually, I continued the administration of aspirin 100 milligram during surgery, not stop the antiplatelet completely. So in summary, for chronic revascularization, now in our series, mean temporary occlusion time was 22 minutes, 23 minutes in 61 bypass of 36 cases, not 33, 36 cases. And actually in my hospital, the surgeon is not limited only by me. That I let my young colleagues to operate this patient with giving a continuous advice during surgery. So this is one of the reasons why we have the relatively long-term temporal occlusion time. But the eligibility of the surgeon is very important. I require the young colleague who can operate the STMC bypass, that they must clear the 20 minutes anastomosis with 20 stitches as end-to-side anastomosis. We had no surgical complication in this series, and the bypass patency rate was 85%, 97% in patient number. Recurrence rates of ipsilateral infarction was 5.6%. And mortality rate was 0. Even if the well-trained surgeon performs a perfect STMC anastomosis with a strict control of diabetes mellitus, smoking, hypertension, and hyperlipidemia, there is an incidence of stroke after surgery because of strong atherosclerosis due to the continuous bad habit of patient's private life, smoking, too much consumption of carbohydrates, sugars, these are the background of a patient, but we have to educate the patient, especially diet, before and after surgery. Otherwise, the bypass, micro-anastomosis, easily occluded. Actually, many of my patients, before surgery, they quit smoking, but after surgery, they start re-smoking. And these patients easily have the occlusion of the bypass. Next, I'll talk about the acute reconalization for stroke. This is another important topic for us. I have been performing the surgical embolectomy for these 20 years, from 1996 to 2021 now. This is a mistake mode. And the endovascular embolectomy first after Nashville Hope in 2015. And we performed the surgical embolectomy even after the failure of endovascular thrombectomy as a third procedure. You know, the first procedure is TPA, intravenous administration. And the second line is endovascular embolectomy. And as a third line, we can try to do a surgical embolectomy. These are the member of the stroke center and Teishinkai Hospital. Under me, there are 12 neurosurgeons, including 3 hybrid endovascular surgeons. These guys are hybrid endovascular surgeons and a neurosurgeon. All the strokes are treated by these members. We had 99 cases of acute reperfusion for intracranial main trunk occlusions in this around 10 years. The target region is carotid, the C1, C2 segment, MCA occlusion, M1, especially M1 segment, and the important thing is basilar trunk and the PCA, P1, P2 segment. These are the very important intracranial main trunk, as well as we have to check the condition of aorta. When we perform the CTA of the brain, that we can detect the occlusion of MCA like this. This is an example. Simultaneously, we can perform the abdominal CT angio like this. And what we should check in abdominal aorta angiography, I always emphasize whether patient have the renal artery stenosis or occlusion. And here you can see it, this trunk. This is a supramesenteric, and here is inferior mesenteric. Here is a celiac trunk. These important abdominal branches is important to check because especially superior mesenteric and inferior mesenteric artery, it a cause of ischemic colitis. Because this kind of patient who needs the reconalization of acute stroke always have the severe atherosclerotic change, and perioperatively, especially after surgery, 1 to 2 weeks, patient have an incidence of the acute colitis with E-legs. So not only brain, but also a general condition should be carefully managed after the reconalization. The diffuse 3 study shows a good result of acute reconalization by endovascular treatment within 6 to 16 hours. Even after 6 hours from onset, out of indication of a tissue plasminogen activator, the endovascular thrombectomy improved the patient prognosis like this. And the Dawn trial, this shows us the good result of the reconalization until 24 hours from the onset. Like this. So, according to these studies, we can try to do a acute reperfusion until 24 hours nowadays. As I told you, as a first line, we can try to use the tissue plasminogen activator. And after the infusing the tissue plasminogen activator, we can transfer the patient to an endovascular angio suite, and we puncture the groin, and we try to do endovascular thrombectomy, regardless within 4.5 hours or more than 4.5 hours. And after the trial of the endovascular reconalization, if the reconalization could not be achieved, we can try to do an open craniotomy embolectomy. These are the indication of the acute reconalization. NIHSS should be more than 10. On diffusion image, the volume of ischemic core should be less than 70 milliliter within 16 hours, 51 milliliter within 24 hours. And susceptibility vessel sign on T2 stir, the TPA is not effective. And diffusion perfusion mismatch is important. We have 118 cases until 2020. Before Nashville Hope, like this, we had a surgical emborectomy. But after Nashville Hope, after 2015, we had endovascular reconalization like this. This is the clinical characteristics that we had the surgical emborectomy, 45 cases. After that, 59, 2015, 73 endovascular reconalization. The main part of occlusion was MCA and ICA. 50%, 10% was a basal top. The majority is anterior circulation, of course. This is a location of occluded vessels in the surgical group and endovascular group, almost similar. I'll show you an actual case of a surgical emborectomy of a left ICA. You can see the slight high signal on the left side MCA territory, and this is a susceptibility vessel sign on the ICA and the M1. Around 10 minutes from a skin incision, you can approach to ICA like this. And the assistant is placing the temporal occlusion temporary clip on the proximal carotid. This is a carotid incision, and pull out the big embolus from the proximal part. And here is the remaining embolus at A1, and the A1 embolus is removed, and still the MCA long embolus can be pulled out. Everybody in OR surprising this finding. And now the proximal temporal occlusion clip is replaced to replace distal to a caudal artery, and all the ICA, A1, MCA is recognized. The diffusion high signal is remarkable, but a patient recovered well like this. Another case, 75-year-old man, the basal trunk occlusion. This is a cardiogenic embolus. The diffusion image shows the less high signal area, but the basal trunk is occluded. The susceptibility vessel sign in basal trunk is remarkable, and right cervical common carotid is occluded in this case. So the basal trunk recanalization is quite important for this patient because of a common carotid artery occlusion right side. This is a right side craniotomy, and I'm approaching to a basal artery through the transribine anterior temporal approach. And in the retrocarotid space, you can see the basal trunk is occluded with the thrombus. I'm putting the temporal occlusion on contralateral PCA, and proximal basal is occluded. The ipsilateral PCA is open. Now, this is the incision at the P1 origin, right side. And the thrombus in the right P1, and the basal trunk is pulled out like this. And the thrombus in the basal trunk is massaged, pushed out like this. Then you can see the blood is coming. This blood is coming from a bilateral superior cerebral artery and ipsilateral P1. The direct stitching with 4-10-0 sutures like this. You can get the hemostasis. This is 45 minutes from a skin incision. Now, you can have the reconalization of a basal trunk. So we had the reconalization at 49 minutes from a skin incision. Within 1 hour. Here is a part of incision. Here is the basal bifurcation, contralateral supercerebral, ipsilateral supercerebral, and PCA, P1, P2, and PCOM. Everything could be confirmed. And you can see that all the vessel is reconalized. The chronic right common carotid occlusion is the modified factor in this patient. Anyway, in this patient, basal trunk perfused the right cerebral hemisphere, so the reconalization of a basal trunk was very important to save this patient. Next case, a 60-year-old man, the less diffusion high signal. The patient has the right M1 occlusion. And you can see, this is a right side M2 inferior trunk thrombectomy. And the MC bifurcation still have the embrus. And the assistant is placing the temporary grip on M1. When we have the reconalization, the assistant immediately closes the M1. But you can see it is very hard to pull out the thrombus. Even we have a reconalization of the both M2, but proximal M1 have a sticky thrombus. Now we could have the reconalization of M1, and I'm confirming whether it is patent or not to a super trunk. And by occlusion of a super trunk, I'm checking the patency to an inferior trunk. Both branch is reconalized. I could confirm it, so that we can close the incision. Then we can open all the temporary occlusion. And then we can close the inferior trunk incision. I'm checking the Doppler sound. Doppler sound looks good, but you can see the ICG shows no reconalization of inferior trunk of M2. So I decided because of a too hard atherosclerotic change of the MCA, even after thrombectomy, the parent artery will be occluded. So I'm performing the STMC double anastomosis to both branches of M2 like this. This is switching to STMC bypass after the thrombectomy, like this. 4 years later, the bypass works well, patient is fine. So the surgical embolectomy, this is one of the advantages of surgical embolectomy. If the reconalization by surgical embolectomy failed, you can try to do a bypass immediately. This is a result of a process time in overall cases, 118 cases. From onset to ER, the patient spent 53 minutes. And from ER to angio suite or OR was 53 minutes. And from a puncture or skin incision to reperfusion, it was 50 minutes. In endovascular group, the 73 cases, ER to angio suite was 1 hour. And growing, onset to ER, 1 hour. And ER to puncture, angio suite was 67 minutes. And from puncture to reperfusion, around 1 hour, even in endovascular treatment. In open surgery, 45 cases, the onset, 57. ER to or around 84 minutes. Here is a bit wrong. And but especially here, from skin incision to reperfusion, around 40 minutes. It's quite fast. And this is a result at 90 days overall result. There are big studies of endovascular reconalization. This is the overall result of us. The modified ranking 0 to 2, around 48%. The endovascular result, around 46%. The surgical result was 54%. And the Tiki score in overall cases, the 75% in Tiki 2B or 3. In the endovascular group, Tiki 2B or 3 was 71%. There was one case of access impossible. And open surgery, the 84% have the Tiki 2B or 3, mainly Tiki 3. We have complications around 1% of deaths and intracerebral hematoma or subacute hemorrhage in 6% in overall. Especially in endovascular, we had 5.6% of deaths and hemorrhagic complication in 7%. Surgeries both have the 4.4% of the deaths and hemorrhagic complications. Finally, I'll show you a rescue of a complication of endovascular reconalization. This is a 69-year-old man, left aortic occlusion. And this is an angiography during thrombectomy using the suction catheter, and still the M2 is occluded. The endovascular surgeon tried to reconalize, but unfortunately, the penetration happened and extravasation is happening. So we immediately transfer the patient to OR and to rescue the patient. And this is the left side front temporal craniotomy, and I am opening the cerebral fissure quickly. And here, the subacute hemorrhage, still continuously the bleeding come. You can see the arterial bleeding from the M to M3 junction like this. We could have the tentative hemostasis, and I'm opening the cerebral fissure rapidly and export the M2 segment completely and put the temporary clip and confirm the injured point. And I am trying to stitch the penetration point by the catheter. Then we can get reconalization like this. But the ICG shows a still occlusion of the left M3 segment like this. M3, M4 segment is occluded by the thrombus. And this is the rescue repairing of the penetration and additional surgical embolectomy. So we had a reconalization at 54 minutes after skin incision. The vessels of MC territory all the reconalized, and patient recovered well. So this is a treatment flow of the acute stroke. From onset, within 4.5 hours, we consider the indication of a tissue plasminogen activator intravenous administration. And after the infusion of a TPA, we transfer the patient to angio suite immediately. More than 4.5 hours after onset, we directly transfer the patient to endovascular embolectomy. And after the failure of reconalization by endovascular, we try to do open surgery, open surgical embolectomy, or if necessary, we can perform the STMC bypass. This is an important flow in acute treatment of stroke. So in conclusion, the overall good outcome modified ranking 0 to 2 was 55%, no significant difference between endovascular and surgical reconalization. Acute reconalization was effective and the neurological prognosis was good with short process time regardless endovascular or surgical. Open embolectomy or emergent STMC bypass can be a third-line treatment after the failure of endovascular reconalization. The advantage of surgical embolectomy is not only to reconalize the occluded vessel, but also to repair the injured vessels during endovascular procedure in very short time. Endovascular and surgery are not versus. These treatments can be collaborated. This is the most important. Thank you for your attention.
Thank you very much, Professor Tanikawa.
Thank you.
It was a beautiful lecture as usual. Beautiful cases, dissections, bypass, microsutures, unusual, at least for us, indication as you presented to us. So we start with the, as usual, asking for Professor Al-Mefty, make your comments and questions, please.
Well, Professor, is so beautiful, beautiful surgery, beautiful results, beautiful thought, and we learned a lot, and we thank you.
Thank you very much.
This is a beautiful operation that I believe that any neurosurgical residents on their first week, they should go to the lab and learn that. Like my mentor, Dr. Fox, made me sit in the lab in my first year and learn it. It just set up the whole brain to do a very fine work, and it's a beautiful operation. And it should be the basic of any neurosurgical training. And so they all should come to you and see how beautiful you do it and teach them. Now,
Thank you very much.
I got two questions was troubling me. And the principle of those questions is the opposite directional flow. That means if you have one vessel, you have a blood coming from one side, and you push a blood from the other side, that will lead to their thrombosis. And I think that idea explains why the original bypass studies, the middle cerebral artery stenosis, did the worst results. The original study, the middle cerebral stenosis, was almost a no-no to do bypass for it because they all stroke. And I think they did because of that opposite directional flow. While I saw that more than half of your cases were middle cerebral artery. So that's one. Now, the second thing is the same idea. I saw you have 10 bypasses, 10 patients, that there was occlusion. 8 of those were one bypass. And I'm wondering if those got occluded, the other bypass got occluded because of the same reason. You have 2 opposite directional flow by hooking the 2 bypasses. Do you think that opposite directional flow will promote the thrombosis?
Yeah, it's a difficult pathophysiology. Yes, as you mentioned, if the patient have the stenosis of M1 segment something, still the anterograde flow is remaining. This may causes the fighting with the bypass flows, and it may causes occlusion of the vessels. This is a big concern in bypass surgery. In a series, we have around 50% of the cases was the MCH stenosis. And now I have been considering that the basically stenosis is not a good indication for surgical revascularization, surgical bypass. But in that cases, in a series, the many patient was symptomatic with best medical treatment, and we have a big discussion with the patient and the patient family whether we should observe or we should perform the bypass. As a result, we perform the STMC bypass. But several cases has occlusion of bypass because of bad condition of the cerebral arteries, and STA as well. The STA condition is not good, so that this is very difficult to have the good result, or to have the good result. It's a difficult. So the stenosis is not a good indication.
My question comes from a dilemma we have in a tumor surgery, that if the carotid was at risk to be sacrificed or injured, and if that patient has a poor collateral on the testing, whatever testing you do, then one will think about doing prophylactic bypass. That means hooking the bypass in advance. Then you take the risk of whatever happened to the carotid you already secured with your bypass. Those prophylactic bypasses get occluded before you get to operate on the tumor. And many times they get the patient to stroke that he did not have or would have. If we want to do bypass prophylactic in a patient that we are going to risk the carotid, how do we avoid the risk? Occlude the carotid anyhow after we connect the bypass? What should we do to avoid a risk from the presence of the bypass that we did?
I think it's impossible to maintain the patency of the both vessels bypass and original the internal carotid. If we perform the prophylactic bypass to such a condition, we should ligate the carotid. Otherwise, we can't maintain the patency of the bypass.
So you ligate the carotid after you connect the bypass?
Yes,
or at
yes.
the time you connect the bypass?
Yeah, absolutely.
But we're doing the bypass because of the possible risk to the carotid, not for sure that something is going to happen to the carotid. So here we are sacrificing the carotid for the possible things that might happen to it. It's a difficult decision to sacrifice somebody carotid and depends on the bypass that we inserted when the carotid might not be injured or might continue to be patent during and after the operation. But you're advising, if it came to put prophylactic bypass, is to occlude the carotid.
Yeah. But to do that, at least we need the similar size of a graft vessel, like a saphenous or a radial artery.
Then in this situation, the EC might not be enough, bring a blood flow to compensate for the whole carotid. Yeah. And that means they need a bigger lumen or bigger conduct bypass.
Yeah.
So that means in this situation, we should do a long venous bypass and not EC.
I usually use the external carotid.
I mean, radial artery.
Radial artery. Yeah. If the radial artery diameter was sufficient enough, I use the radial. But some patients have the very small radial artery. Then in such case, I use the saphenous from lower leg between ECA and the MCA. And some skull-based tumor patient has already have something the invasion of ICA and the ECA in the neck from the skull base. In such case, I use the vertebral artery V3 segment. So the V3 to M2, we can use the saphenous or radial artery graft.
With the radial artery graft.
Yeah. Okay. Anyway, yeah, thank you very much.
Great. I invite everyone who wants to make questions and comments to turn on your camera. And I'd like to invite the Dr. Jorge Mura from Santiago, Chile. Dr. Mura has a good experience with bypass, so I'd like to hear your thoughts about this.
Yes, thank you very much, Jan. For me, it's a great honor to hear Rokuya. I know him for a long time. And we both share these concepts about the ischemia. I think in the future the ischemia will be very important for the neurosurgeons, and then it's very important for all the young guys to be trained in arterial suture and reconstruction and revascularization, mainly the STA MCA bypass and the occipital pica bypass. I think we talk a lot about the high flow or second generation bypass, but now with the flow diversion, the indication of high flow is going down, very high success with the flow diversion in intracavernous lesions. And the indication in tumors is very seldom. I was very excited when I started to do bypass, to do this kind of bypasses in meningiomas or whatever. But now I think the key of the surgery is the preservation of the structures. And then the main problem as well for the skull-based tumors is the perforators and for example, the anterior choroidal or the perforators of the carotid bifurcation or the posterior cerebral artery or basilar bifurcation. And then now if you see the most of the authors doing bypass surgery, and we try to follow them, we do a lot of first generation bypass, STMCA for ischemia. We do a lot of atherosclerotic disease. Of course, a lot of moya moya. For us, it's not as frequent as for the Japanese or Chinese people. You know that we have a Shubin with the 8,000 bypass in ischemia. And the second thing now I think is very important for the neurosurgeons to be trained is for the intracranial bypass. I think that the reconstruction in situ of the lesions is very important. And you can use in that case the STA, the radial artery, or whatever you need. Okay, but I think that we must be involved in the ischemia. As Rokuya showed in his presentation, the endovascular guys have the ischemia with the neurologist, and we must be involved. And the way to be involved is the hybrid neurosurgeons, but neurosurgeons who can operate. Non-neurosurgeons can they only do endovascular therapy. I think the neurosurgeons must be involved in the ischemia, because if you see the diffuse 3 of the Dawn study, the success rate of them is 80%. The highest success of PK 2B or 3 is 90%. And then if you see the figures of the ischemia in a huge volume center like I work, you have for example 100 cases of endovascular thrombectomy, and they have a 90% of success. You have 10 cases, and you must do a microsurgical thrombectomy. And then I think the thrombectomy is not well known for the neurosurgeon. And that's one of the things that I learned from Rokuya, that the thrombectomy in a stroke can be done for a well-trained neurosurgeon. It's much more easy to do a thrombectomy than an STA-MCA bypass. You only need to know to do 2 or 3 stitches. That's it. With 3 stitches, you resolve the problem of the patient. For STA-MCA, you need 8 or 10 stitches. And it's very hard to do an STA-MCA. It's more difficult. And then I think that, in my opinion, what I learned when I heard Rokuya in his lectures is the ischemia is very important for neurosurgeon, not only for endovascular therapy.
Yeah. Thank you, Jorge. Professor Tanikawa, any comments about that?
Yes. I agree with what Jorge mentioned. As I showed you, the surgical embolectomy is easy. Just expose the vessel and incise it and then stitch it 2 or 3 stitches. It's much easier than STM's small bypass. You know, the vessel we should stitch in acute embolectomy is proximal MCA or ICA, the relatively larger vessels. It's easy to stitch. But the STMCA bypass, especially in STA M4, M5 bypass, the recipient size of MCA less than 1 millimeter, the vessel wall is very thin, and it's much more difficult to stitch the proximal ICA MCA. So the acute surgery for ischemia to reconstruct surgically is a relatively easier procedure and a very effective procedure for the patient. So we neurosurgeon can run it. We should try to be involved with the endovascular surgeon. We need the discussion with the neurologist and endovascular surgeons as a team. It's my opinion.
Very good. Also as
Jan,
a pen, hey, Professor, please.
just on that point, you know, the endovascular people now kind of pushing a little bit, doing more middle cerebral artery aneurysm with endovascular. And those are the one which the coil is gonna come out in the middle cerebral and might cause the thrombus. Are you, anybody seeing more need for surgical embolectomy because of the endovascular coil treatment?
Sorry, I couldn't catch up. What do you mean?
When they do middle cerebral artery aneurysm with coil, that coil more apt to go out the aneurysm or more difficult and might cause a thrombus of the middle cerebral artery itself. And that way, the only way to treat them is to operate and pull the coil out and the thrombus out. Are you all seeing more of these cases?
Yeah,
now?
I have no experience of the surgical embolectomy after the coil embolization, because such a occlusion after the MCA aneurysm coiling, the occlusion of the vessel usually much more distal part. So it's an out of indication of the acute embolectomy. I think.
Now, here a technical question for you, and only a bad guy like me will ask. I was very appreciative of your saying that you take the stitch from inside to the outside, so you do not dissect the intima.
Yeah.
And I noticed that you did that so beautiful on the two corner stitch from each side. But for the rest of the stitches, you don't need to do from inside to outside?
Yeah, it depends on the situation. Before penetrating the vessel wall, we should confirm the vessel condition, whether which side have the bad condition or good condition, or which side is easily dissected intima layer. During preparation, we can confirm it. So it depends on the cases. But many of the cases, as I showed you, in the donor vessel, we can put the state suture on the heel and the toe. And in such situation, we can we can ensure not to dissect the intima layer with a counterforce from with the other side micro forceps, and from the other side needle penetrate. We can avoid the intima dissection, but the problem is during regular stitches in between the state sutures with the MCA and the recipient. If you try to penetrate from in a MCA vessel wall from adventitia to inside, if the MCA have the very sclerotic change, MCA intima layer easily dissected. This is a very dangerous situation. So when we make the arteriotomy on the MCA, we can confirm whether the MCA have the easily dissected condition or not. Do you understand what I mean?
Oh, sure.
Yeah. So always we should confirm the condition of the vessels, both vessels, recipient and donor.
Very good. I'd like to hear Dr. Juan Castro, who has one of the greatest experience in bypass surgery here in Brazil. Dr. Castro works in Santa Casa de São Paulo in Professor Vega's team. And Castro, please, I'd like to hear your comments, your questions.
Thank you very much, Professor Tanikawa. Great lecture.
Thank you.
I have one technical question. Why you don't use the high flow bypass even with a venous or arterial graft as a first option in that cases?
You mean the high flow bypass for ischemia?
Yes.
For chronic the ischemic condition, I'm afraid of the hyperperfusion after surgery. Even STM bypass, we have several hyperperfusions. So usually I do not use the high flow bypass for chronic ischemia. We have to confirm the CBF condition with a Diamox challenge with a single photon emission tomography. And if the patient have a severe vascular reserve, the high flow bypass is dangerous.
Okay. Even when you perform a perfect anastomosis, a perfect suture, you may have an occlusion of the bypass. As Professor Al-Mefty says, the competition of the flow may be an important factor for the occlusion. If you made an anastomosis with a high flow and unique, maybe you can guarantee your bypass. I have a few cases operated with this technique, and I think that the important factor of the high flow maybe is vital for this surgery. What do you think about this?
Yeah. The same thought I have considered. Yes. So for especially for the pathology of stenosis, the high flow bypass may effective to avoid such the bypass occlusion after surgery. Yeah. But that it depends on the patient vascular reserve. If patient have the good vascular reserve with a stenosis of the parent artery, we may choose the high flow bypass.
Okay. Thank you very much.
Thank you.
Great. We have also a young generation member here, Dr. Carlos Eduardo Ferrares from Belo Horizonte. This young neurosurgeon is doing a very good job over there. So, Carlos.
Hello, Professor Gian. Thank you very much. Professor Tanikawa. Good evening, good morning. It's always a pleasure watching your classes. I've been following your work. I'm a great admirer. And I have actually two questions for you. First one, we know that we have been doing some open surgery embolectomies here, and I have had the bad luck of encountering some cases with a heavy calcified carotid ICA. And in those cases, I had two cases actually in which I weren't able to open those arteries.
Sorry, just a moment.
Okay.
Your question was too long. That's why he turned off the camera.
Too boring.
Yeah.
Yes, the next one is even worse.
Yeah. Yeah.
Vambora.
Yeah. Where's Professor Colley, our ombudsman? Professor Colley is our ombudsman, so we'd like to hear some comments from him also.
Professor Colley could answer all the questions.
Exactly.
So ask colleagues.
Yeah. Nobody turned on the camera. We have more people with camera off than on. I'm glad to see Arturo from Mexico also here with us tonight. Hey, Arturo, good to see you.
Hello, my friends. How are you?
Yeah, fine. Thank you. Thank you for joining us tonight.
Oh, it's a pleasure to see all together in this beautiful webinar.
Thank you.
Reciba hug from Mexico City.
Yes. You prepare your question. You are the next. Okay.
Excellent. Okay.
Okay. So Carlos.
Sorry, disturbing.
No problem, sir. No problem.
Okay. So Professor, I'm sorry.
Yeah.
I was talking about open surgery embolectomy. Okay. So we know that Asian people have a higher percentage of atherosclerotic cause for a carotid occlusion, and I have had 2 cases in which I was trying. I went to do an embolectomy, but I found a heavily calcified carotid, and I wasn't able to open the vessel. So I had to do, I think, similar what you did, and went to an STA-MCA bypass. And I think I took too long to do it. It was around 2 hours with everything. But I didn't get a great result. And I couldn't foresee that in the previous exam. So I was thinking that maybe if I had known, if I had thought about it, the calcified carotid, I could have jumped straight to the STA-MCA bypass, maybe a double barrel bypass. And I would like to hear your comments on that. And I have a second question, if you could please give me the honor. What are your thoughts?
Yeah. This kind of patient often have the very strong atherosclerotic change. And as you mentioned, the calcified carotid is very hard to incise. Even if you could incise it, the inside of a vessel has a very strong atherosclerotic change with plaques.
Yes.
And impossible, even if you pull out the thrombus, you can't recognize it. But in such case, immediately we can switch to a bypass using an STA graft. As I mentioned, the high flow bypass in acute ischemia is too dangerous, too much. So the low flow bypass with STA is good enough in an acute stage. And if we can perform the CT angio, we can detect the calcification of the vessels easily. So I usually perform the MRI, diffusion image, T2 star, and MRA. These sequence can be finished in 10 minutes. And continuously, we transfer the patient to a CT angio suite and check the CT angio. And we transfer the patient to angio suite. So I think you should try to use a CT angio before the treatment, that we can check the calcification from neck to head.
Yeah. And the next question, if it's not too much trouble, I think that something that we have been facing is something, it's difficult to convince our neurologists that we are an option. As you said, they still find us as being enemies. Like want to steal them job, and that's not it. But something that we can always try to talk to neurologists. They love papers, and I think it's hard to publish this kind of results, this kind of papers. We have had a few papers denied, and we don't see much publications. I don't know about you, if you're planning of publishing your series. We just get rejected. They don't let us publish.
Yeah. I can understand what you mean. Yeah, even neurosurgeons, many enemies around us. Because our group have tried to publish our result, the surgical emborectomy result, including endovascular, the reconalization. But that was a neurosurgery paper in Japan, but they rejected, completely they rejected. So I don't understand what they rejected, but because the neurosurgeon who tried to perform the surgical emborectomy is a minority, very minority, and so they don't accept it. They don't want to accept it. What we are trying, but I don't care. I don't care. We can try it continuously to improve the patient result. So as I mentioned, nowadays the first option is TPA and simultaneously endovascular. But after endovascular, still we can save the patient if the patient condition allowed us to perform the surgical emborectomy. So that's it. Sometimes many of neurologists is not cooperative with us. I know. Actually, in my hospital, we have no active neurologist for stroke. So in my hospital, neurosurgeons are all managing stroke, not only surgical cases, but also medical cases. This is a special condition. This is the difference from you. In Japan, the neurosurgeons mainly take care of the stroke patient, medical stroke patient.
Yeah, that's not what's happening in Brazil. But very much, Professor. Thank you very much.
Dr. Tanikawa, you just show us that your mean time for occlusion is around 20 minutes for the whole procedure. So how often you have some changes in the SSAP and MP during your whole series of bypass?
Basically, when we perform the STA-MCA bypass, like distal to M2 segment, I mean the STA M3 M4 bypass, we have no change of MEP or SSAP. But the very occasionally the MEP disappears in STA M2 anastomosis, especially in STA supratrunk bypass, STA M2 supratrunk bypass. The MEP occasionally the occluded or amplitude decline, but very rare. Basically, even M2 bypass, it's relatively safe. Within 20 minutes, less than 30 minutes, nothing happens.
Let's hear our friends from Mexico. I just saw Gomez Amador, but I am seeing Arturo. Please, Arturo Ayala.
Thank you, Jan. A beautiful lecture, an amazing lecture, Dr. Tanikawa. My
you.
question is, in countries like Mexico, or many Latin America, or even in Africa, Asia, many hospitals don't have endovascular team. Then, in which cases you can consider that the surgical thrombectomy, like first option. In that case, what is your advice about the timing to do the surgery?
Basically the indication is the same, regardless in endovascular or open surgery. The indication is the same, timing is the same. So we can try it if there are less high signal area in a diffusion image. We can try it. Like diffuse study, we can try it until 16 hours from onset. According to a Dawn study, we can try it until 24 hours. So the golden time, 10 years ago, the golden time for acute revascularization is less than 6 hours. It is said less than 6 hours, but nowadays it is extended to 16 hours or 24 hours. So we should have the examination using a diffusion image and FREA image, and if until 8 hours, we should check the diffusion FREA mismatch. Very acute phase, we should check the diffusion perfusion mismatch, but until 8 hours from onset, we should check the diffusion FREA mismatch. And if possible, we can try to recognize the main trunk, regardless ICA or MCA. Do you understand?
Yes, sir. Yes, sir. Well, in the case that the first option is the thrombolysis, and in your logarithms say that you can wait 4 hours, and obviously the second step is endovascular, but in this case we don't have enough hemodynamic rooms. Then we can wait the same 4 hours for take the decision to the surgery.
Yeah. After TPA, I wait the 1 hour. We can decide whether we go to surgery or not around at 40 minutes to 50 minutes after the beginning of a TPA infusion. Then we call the order the preparation of the craniotomy. Then we can transfer the patient around 1 to 1.5 hours later from the TPA infusion, like that.
Thank you so much, sir, and beautiful lecture.
Yeah, welcome. And additionally, the half time of TPA is very short, around several minutes. So there are no concern of the bleeding hemorrhagic complication even in open craniotomy after TPA. Don't worry.
Okay, thank you, sir.
Yeah.
Let's keep in Mexico. Juan Luis Gomez Amador, thank you for joining us.
Yes, sir. I think Professor Al-Mefty wants to say something first.
Oh, please. Professor has always the word.
No, I wish Professor Yazergil is listening to us. The first operation he did was embolectomy. And then he came up with the bypass, ECHD bypass. So the first microsurgical vascular revascularization was the great Professor Yazergil doing embolectomy on the middle cerebral artery. And you could look it up. And I think I still saw, or on some of his presentation or show it to me, the original slide of that operation. And he also, and I saw the original first EC-IC bypass. What I want to say, those were 1967 and 1968. That's over, how many years is that? 50 odd years. And that's art still help the patient, and we should not abandon. And thank you, Dr. Tanikawa, for doing it so beautifully and teaching it and everybody else. But why I'm saying this, because you just mentioned there is out there anti-surgical ambient. You couldn't publish it. He couldn't publish it. They're afraid to turn it down. They're turning it down. Those are not they. These are neurosurgeons who are reviewing that beautiful work. So I just want to say that we should never forget the great things Professor Yazdajiel brought, and that is durable. It was 50 years ago when he showed a picture exactly what we're saying. This is a beautiful today, and we should do.
Excellent.
Thank you.
I can see Juan Gomez Amador, please.
Yes, sir. I just want to thank Professor Tanikawa for this excellent lecture. What we are seeing in this evening was a well-prepared surgeon who is efficient and who is available to perform these complex surgical procedures when it's needed. And as Professor Al-Mefty said, Professor Yashargil used to say to us that when he started to describe the cisterns and how to open and how to develop the surgical corridors, nobody believed him. So everybody was thinking, this crazy Turkish guy is saying something nonsense. So in the same way, I think the future of microsurgery is as Professor Tanikawa showed us, following the steps of Professor Al-Mefty with an exquisite technique, but also with precise analysis of the data. This is very important. I would like to ask you, Professor, concerning to laboratory training, there are many people in the webinar. What is your concept? How the neurosurgeon should be trained in these special techniques?
Oh yeah, the bypass training is necessary, of course, and I recommend my young colleagues to use artificial synthetic tubes. It's good enough for training. You can begin the training anytime during your duty in the night in the hospital, in your room, and anytime you can stop it, and you can go to patient ward, or something, and then again return to your room, and again re-anastomosis. So it's convenient to continuously perform the training. When I was a resident 30 years ago, I used a rat in laboratory, but during my duty, when I go to patient ward and I return to laboratory, the mouse disappear. But you can find the rat easily because you can follow the foot stamp, and at the corner of the laboratory, the rat is passed away. So it's a big trouble if the mouse continuously escaping in the hospital. It's an accident, a terrible accident. But artificial tube cannot escape, so I recommend to use the artificial tube. Anyway, continuous training of anastomosis is necessary, but as well, we have to educate the young guys how to get the hemostasis completely, not only cauterize, but also put the Sagicel, which hemostatic material is appropriate? Sagicel, gel form, or cauterizing, or bone wax, or fibrin glue gel form something. Which is appropriate to this kind of hemorrhage, we have to distinguish them, and young neurosurgeons have to learn the exact way of hemostasis. Otherwise, we can't have the precise neurosurgery, not only vascular micro-anastomosis, but also a tumor dissection, skull-based dissection, skull-based drilling, anything. So the hemostasis education is as well very important.
Thank you, sir. And one question: are you still training today?
One thing, because you love it. That's the most important question. And I think today everybody should go to Dr. Aboud to learn this. That model he has with the blood flow is the perfect model on a real anatomy, the cadaver anatomy. It's the perfect model to learn all bypasses in vascular surgery. You could suture a tube, but it's not. You could follow the rat in the hospital and catch them. It's not. Dr. Aboud, the model is really as close as doing this operation in real life and real time. And I think that's how the training and the practice. But you need the motivation. You know, my son is a neurosurgeon. Yep. On his first month of neurosurgery, for his birthday or whatever it is gift, he insisted that I get him microscope to put in his home on the dinner table so he could practice all the time. The motivation of the trainee, that's the excitement, that's what you need to be able to train.
Yeah. Exactly.
We had Dr. Aboud in this room, but he's no more in the room. Also, you have Dr. Magaldi, who has a placenta model for the practice. Magaldi is in the room, but the camera is off. And look at how beautiful is the background of Dr. Roberto Leal. Dr. Roberto Leal is inside of a cerebral vascular surgery, as you can see, literally. Dr. Leal, please.
Yes.
Yeah.
Yes, Jan. No, thank you.
Beautiful background, beautiful.
Yes, yes. And that's what I'm going to talk about, you know. The beautiful lecture, Professor. And I'd like to emphasize the importance of this training also in skull-based tumors. During this removal of a petrocranial tumor, meningioma, we need to perform a suture in order to preserve the ICA. So we need this training for different surgery, not only for ischemic surgeries, ischemic anastomosis. Thank you.
Thank you.
So any other question or comment?
Yeah, may I?
Yeah, yes, please.
Professor Tanikawa, are you still practicing in the laboratory these days?
Me? No, I don't have the practice now. But when I was the resident, I often did.
Because you practice every day in the OR, right? That's why you don't need it.
Too much.
For for those who perform a bypass once a month, once every 3 months, I believe that it's very important to go to the lab 2 or 3 days before the surgery, practice a little bit, and then to prepare for the surgery. I can see that Marcelo Magaldi, thank you for joining us tonight, Marcelo.
Yes, pleasure.
Marcelo developed a very good placenta model for lab practice. Please, Marcelo, I'd like to hear some insights from you.
Yeah, thank you very much, Professor Tanikawa. It was an excellent lecture. We have met in Zurich in 2020, and it was a great pleasure to hear your presentation again. I just would like to add to all participants that we published in last February, I think, at World Neurosurgery, a placenta model for stroke microsurgical thrombectomy. We could keep the natural clots inside the vessels, and it was quite a good training for dissect and do all kinds of sizes of arteriotomies and all kinds of sutures, and it was quite a realistic training. It's published already. But I agree with Professor Tanikawa and Dr. Carlos Eduardo. We have a few cases done in real patients already, but we are struggling to get it published. We are really struggling to do it. But Dr. Carlos Eduardo, the youngest, maybe the youngest doctor with this experience right now, he has trained a lot in the placenta model, and I think he acquired a great ability. It's not the rat that may be the best, it's not Dr. Abud's perfused model, but it's different from plastic tubes, and you get quite a real good sensation of biological tissue. That's what I would like to add. Thank you very much.
Thank you, Marcelo. So we are almost 2 hours in this webinar. We have more than almost 200 people in this platform, and maybe a little bit more in the YouTube. So I'd like to hear the final remarks from Professor Al-Mefty and Professor Tanikawa before we closing.
You haven't heard from me enough. I've been talking for an hour.
Yeah, it's always nice to hear from you.
No, I think this should be the basic of the basic in any neurosurgical training. I see to be a vascular surgeon, it's the basic of doing anything else. Roberto just said that in a tumor, many times we nick an artery or have a hole in the artery. You need to know how to repair and suture those arteries. And that's one. Two, these things works. You just saw the results. It saves some people's life and patient and function. So it cannot be abandoned, and it's not going to be abandoned. Here it is. We're talking about it more than 50 years after it was first described. So it's durable. Yep. What's left is to create that excitement and the motivation in the new people and to provide them with the opportunity to practice and be trained. But it's so beautiful that Professor Tanikawa, and we really appreciate it and thank you for presenting it.
Thank you, Professor Al-Mefty. Professor Rukuya Tanikawa, again, thank you very much for that. I'd like to hear your final remarks before Dr. Vega closes the session.
Thank you, John. Yeah, today I talked too much. Thank you very much. It was a wonderful time to share the time with you. Anyway, as Professor Al-Mefty mentioned, the continuous training, the continuous motivation is very important for us, and especially not only the micro-anastomosis training, but also the skull-based anatomy in cadaver head. It's a very important, not only for a skull-based surgeon, but also for a cerebral vascular surgeon. It's a very important training. So we should continue the training in cerebral vascular and the skull-based cadaver head, everything. Thank you very much.
Look at my samurai sword.
Right, yeah.
I have here.
Yeah.
Beautiful.
Yeah, that's here.
Yeah. Professor Vega.
Thank you, Professor Tanikawa, for accepting our invitation and for sharing your time with us, and for your outstanding lectures and lessons. Thank you very much. Thank you, Professor Al-Mefty, for the opportunity, the audience, and the panelists for the discussion. Until next time. Thank you. And thank you.
Thank you.
Thank you,
George.
Professor Vega. Thank you. Thank you, Aziz.
Koji, Jorge, Carlos, Juan Luis, Juan Castro, Duarte, Antonio.